Okay.
We're good.
All right. So welcome everyone. My name is Gloria Reeves. I'm the research vice chair of the department. I'm honored to introduce our grand rounds today while our chair is away. I wanted to first start out in the spirit of gratitude and thanks post Thanksgiving that we are especially grateful for our wonderful trainees. We have trainees across many research and clinical education disciplines, and we're extremely grateful for you. Please know that the favorite part of the faculty's day is the time that we spend with you, and we appreciate the opportunity to learn from you. And in that spirit, we have an esteemed expert who's going to be sharing an opportunity for a future, sharing information on opportunity for a fellowship training. So we are delighted to be joined by Dr. Robert Innes today from NIH. Dr. Innes is the chief of molecular imaging branch at NIMH. I understand from your bio sketch, Dr. Innes, you were a precocious scholar. I noted that you were a valedictorian of your high school at Newport Free Academy, which is quite impressive. Early start.
A public
Dr.
institution.
Public institution. Is that in New York?
Yeah, it's public school. Yeah,
Is it still there?
yeah, it's gone downhill.
Oh, okay. Okay. Yeah, I thought Newburgh was in New York. And Dr. Ennis received his MD and PhD degrees from Johns Hopkins and then trained in psychiatry at Yale before joining the faculty there. And he was recruited and joined the faculty at NIMH in 2001. And his career has been marked by the development of important new PET ligands, most notably to image dopamine transporters and neuroinflammation, and the subsequent use of these ligands to quantify targets relevant to pathophysiology of neuropsychiatric disorders. I'm going to go a little off script from his bio because I had a chance to see his bio sketch, and I just wanted to highlight a couple additional things. Is that Dr. Innes's just profound commitment to mentorship and to the future of our field. He's won many mentorship awards, and his mentees have been quite successful. I'm just going to highlight most recently the 2024 NIMH Directors Award for Outstanding Mentor for personalized mentoring and consistent success in helping staff and trainees reach the next steps in their careers and leading by example as a role model for scientific excellence. I also want to highlight an important contribution that often gets uh, uh, overlooked in all the great innovation of exciting new research is Dr. Innes's commitment to really improve the structure in the field of neuroimaging by working with international work groups from things that are really fundamentally important, which is just having uniform consensus around nomenclature and establishing standards so that benefits everyone in the field. So we're very grateful to have him come and present today. And I'll turn to you, Dr. Innes, and I will man the chat. If any of the trainees on the chat are interested in having follow-up communication with Dr. Innes about the fellowship opportunity, please reach out to me and I'll put together a list for a follow-up meeting if there's anybody interested. And we'll take questions. We'll plan on the last about 10 minutes of the presentation. So thank you so much, Dr. Innes, for joining us virtually today.
Thanks very much for allowing me to speak. And the title of my presentation is Exciting Developments for Positron Emission Tomography in Oncology, Neurology, and with a little bit of humor, dry humor, even psychiatry. With regard to conflicts of interest financially, I have no conflicts of interest, but I do want to mention that I'm using this to try to recruit a PGY4 resident or clinical fellow to work with me in my lab. I'll come to that at the end. Um, Exciting developments for PET in oncology and neurology. Let me just summarize some of that. Um, Specific targets, proteins, have FDA-approved PET radioligands for diagnosis. For an example I'll give is prostate-specific membrane antigen, which I think now has 3 different radioligands, which are in clinical use to diagnose primary and metastatic prostate cancer. Radio-labeled probes for beta amyloid and tau protein for the diagnosis of Alzheimer's disease or mild cognitive impairment. These targets are linked to therapies. So, for example, with regard to the PSMA, prostate-specific membrane antigen, there can be radiotherapy in the prostate via what's called a theranostic agent. You can have a diagnostic label and also a therapeutic label so that it can kill the cancer. I'll show that. Or it can be used, as in the case of beta amyloid, to select dementia patients for anti-amyloid therapy. After all, you don't want to treat with an anti-amyloid if the subject doesn't have amyloid. Then the question I'm going to ask, and I'll come back to it at the end of the talk and ask you to consider it while I'm talking, are these fantastic, exciting developments in oncology and neurology models for PET in psychiatry? So keep that in mind. So with regard to prostate cancer and prostate-specific membrane antigen, prostate-specific membrane antigen, PSMA, is a carboxypeptidase that is highly expressed on protein cancer cells. The expression of PSMA has been identified in more than 95% of prostate tumors, and there's a direct correlation between PSMA expression levels and tumor aggressiveness, disease recurrence, and time to progression. So clearly important for diagnosis. Here's an example of an F18 labeled radioligand for PSMA in a normal person. You can see the distribution of radioactivity in various organs of the body. Here's an example of a man with prostate cancer. And let me see if I can put on my pointer. At a higher view, you can see this chain of lymph nodes, which has metastatic prostate cancer. Okay. Theranostic, this is a term that I was not familiar with until recently. It's a combination drug via different radionuclides. So the diagnostic component can be a PET ligand to localize the tumor. For example, this F18 labeled PSMA can localize and give a diagnosis. The F18 positron generates 2 high-energy gamma rays, most of which pass through the body. But if you label this same compound with lutetium-177, lutetium high energy emits a high energy beta, which deposits a lot of energy and will kill the tissue or the cells that it's next to. So you give the radio-labeled probe with the lutetium, it'll go to where the tumor metastases are, and it will kill the tumors. Here's a absolutely dramatic example. This is not typical of someone who has widespread metastatic prostate cancer and then was given 4 cycles of this lutetium-177, and it sort of wiped it all out. So there can be some dramatic treatments, but the point is that you can have theranostic agents. With regard to the brain, the neurology, this is the first article that showed the imaging of amyloid, an abnormal protein that accumulates in Alzheimer's disease, labeled with a compound. Here's a normal control on the far left. This is a normal control with a little bit of memory. This is someone with MCI, mild cognitive impairment. And the amyloid builds up to pretty much a maximal amount in MCI. And then for some reason, it progresses to full diagnosis of Alzheimer's, but the amount of amyloid stays the same. This paper was published in 2004. The FDA approved the first radio-labeled probe for amyloid in the brain in 2012, in only 8 years. So the approval for the PET diagnostic agents, PET and other diagnostic agents, is much, much more rapid than for a therapeutic one. These antibodies have use. So this was the publication, 3 years ago now, of how an antibody, they treat the Alzheimer's disease with an antibody to beta amyloid. And somehow, why is that? I don't understand. It gets the amyloid out of the brain. And by this, it slows progression by 6 to 12 months. And this is the first report of that article in the New England Journal. There are, however, significant side effects, bleeding and edema in the brain, which require annual MRI. So this is very exciting. This report is the first report of a disease-altering treatment in Alzheimer's disease. Okay, so major developments in neurology. PET radioligands are FDA approved for accumulation of tau and amyloid. They're diagnostic and assessed, and it can also be used to assess therapy. So that when these subjects in the last article, that last slide, were treated with an amyloid antibody, they scanned them before and after. And it really, in many individuals, just completely removes the amyloid in the brain. PET radioligands are being tested now for alpha-synuclein, which is a protein that accumulates in Parkinson's disease. So these are exciting developments. Is PET in oncology and neurology leading a path for psychiatry? Please keep this question in mind. Okay, so I'm going to describe two pathways for PET to explore pathophysiology in psychiatry. The first will be studies from, this is work from my lab now, and it's trying to look at cyclic AMP activity. Cyclic AMP is a second messenger, intracellular second messenger, widespread in the brain and the body. And I'm going to show how that's probed with radioligands that bind to phosphodiesterase 4. PDE4 metabolizes cyclic AMP. The other I'm going to describe, number 2, is inflammation. It's probed with radioligands for cyclooxygenase 1 and cyclooxygenase 2. COX-1 and COX-2. So starting with the cyclic AMP activity, phosphodiesterase 4, PDE4, is the primary enzyme in the brain to metabolize cyclic AMP. In the brain, PDE4B and PDE4D are the most studied. Inhibition of 4B has antidepressant-like effects in rats, and inhibition of 4D, as in David, is procognitive in animals and in one human study. The PET radioligand that we initially used was C11 roliprem, and it binds to all 4 subtypes, A, B, C, and D. And I will show you how the binding to roliprem can be used as an indirect biomarker of cyclic AMP activity. And I'll show you that with this radioligand, we found that there was decreased roliprem binding, suggesting decreased cyclic AMP activity during a major depressive episode, and that it was increased after 2 months treatment with an SSRI. With regard to PDE4B, PDE4B is also involved in peripheral inflammation, and inhibition of PDE4B is known to be anti-inflammatory in the periphery, and there are approved drugs that inhibit PDE4B that are anti-inflammatory, like, for example, in psoriasis, COPD, and COPD. Okay, going backwards. So here's a simple diagram of a cyclic AMP cascade, thinking about it for the brain. And serotonin or norepinephrine, shown up here, can act via beta-adrenergic, different G protein coupled receptors and GS to act on cyclic adenylyl cyclase to increase the production of cyclic AMP. Cyclic AMP activates PKA. Protein kinase A phosphorylates several proteins, including CREB and others, leading to neuronal plasticity and cell survival. The signal is stopped in the brain by phosphodiesterase 4 because it metabolizes cyclic AMP to the 5' AMP. And what we're going to do is have this radio-labeled ligand, which binds to and is also an inhibitor of phosphodiesterase 4. It's important to note that there is a feedback mechanism such that the PKA phosphorylation activates PDE4 and increases roliprem affinity about 10-fold, supposedly. So that here the signal is terminated by PDE4. Activation of pKa phosphorylates PDE4, which activates it and gives more metabolites. So it's a feedback system. If you have too much cyclic AMP, you'll increase pKa and increase the activity. So it's a modulatory feedback, negative feedback system. Well, in order to see whether this was true and can be measured with PET, we injected, this is a coronal section of a rat brain, and we injected both activators and inhibitors of pKa, protein kinase A. And you can see here that if we injected dibutyryl cyclic AMP, an activator of pKa, there was increased radioligand binding on that side of the brain. Then you might say, oh, well, that's just due to increased blood flow or increased activation. And the answer is no, because we also have the inactive stereoisomer, the S form, and there's no difference between the right and the left. So if you activate pKa, it will phosphorylate PDE4B, increase the radioligand binding. We also looked at inhibitors, and we found the opposite effect. Okay, so phosphorylation of PDE4 increases enzyme activity and rolipramb's inhibitory potency and its binding affinity. Local injections, as I've mentioned, to increase or decrease the activity of pKa have the expected effects on rolipram binding that we showed you in rats. It's a feedback mechanism whereby cyclic AMP stimulates pKa phosphorylation of PDE4, which increases enzyme activity, thereby metabolizing cyclic AMP. We also measured the density and affinity of PDE4 in rats, both in vivo with PET and postmortem in vitro. And what we found is that the affinity was decreased 5-fold after death, consistent with the rapid dephosphorylation of PDE4. It's dephosphorylated so that there'd be decreased affinity of radioligand binding, and that's what we found. So taken together, what this means is that C11 rolipram PET in humans provides a unique in vivo measure of PDE4 density and affinity, which is related to enzyme activity, that is not possible in postmortem tissue. So within minutes of death, or 30 minutes of death, the enzyme is dephosphorylated apparently, and you'll not be measuring the amount of the active form. So if you want to measure the active form, the phosphorylated form, you're going to have to do that in vivo. And C11 rolipram, a PDE4 inhibitor, inhibits all 4 subtypes is one way to do it. To see if this same sort of thing occurs in human subjects, we looked at McEwen-Albright syndrome. It's a rare mosaic genetic disorder in GS alpha. That's the G protein that stimulates cyclic AMP production. And it's for certain organs or portions of organs it's expressed and symptoms. And so one of the most visibly obvious abnormalities in these patients is they get fibrous dysplasia, a buildup. I mean, the bone is soft and built up and fibrous. And in those areas, in those portions of the bone, there's known to be increased cyclic AMP and increased activation, therefore. And so we see increased rolipram binding because we presumably have the pKa phosphorylation there. We can also image that distribution in with sodium fluoride. So the sodium fluoride goes to rapidly remodeling bone. So this bone is being rapidly remodeled, and that's where you can pick up metastases. You can also pick up these abnormalities in these patients. So it's showing that whereas an increase of cyclic AMP in regions of the bone, we have increased binding consistent with this theory. So our study in major depressive disorder is summarized here. Unmedicated patients with MDD, major depressive disorder, during a major depressive episode had global 18% decrease of rolipram binding compared to healthy subjects. And this is consistent with the theory that I learned in medical school, that depression is caused by low cyclic AMP activity. SSRI treatment for 2 months increased the roluprem binding by 12% in the 23 patients who completed that. And this finding is consistent with numerous animal studies going back 40 years, that chronic antidepressant treatment, not acute, but chronic antidepressant treatment, upregulates the cyclic AMP cascade. So this was confirming these two theories about the cause and the mechanism of depression and the mechanism of action of many antidepressant medications. So because of this, you could imagine that PDE4 would be a therapeutic target in depression, but I can also mention in dementia. Animal studies suggest that subtype selective inhibitors may help. Inhibit PDE4B, you have antidepressant-like effects in animals. Inhibit PDE4D, and you have pro-cognitive improvement in animals. The problem with using roluprem is that, roluprem was developed in the late 80s and early 90s by Pfizer as an antidepressant drug because, if in those days you thought that depression is associated with those low cyclic AMP, let's treat with the PDE4 inhibitor. It'll increase cyclic AMP and people will get better. The problem was that it caused severe nausea and vomiting. And since the time of those studies, the field found that there's not just PDE4, but there are 4 subtypes. And the dose-limiting effects, and this is really severe nausea and vomiting, was probably caused by 4D. So we developed radioligands for selective or preferential, I should say, for 4B and 4D. Okay, here's the PDE4B in a monkey brain. So this is the MRI is on the left, and the middle is the baseline PET scan. So by the way, when you give the PET radioligand, it's given in tracer pharmacological doses. It occupies less than 1% of, let's say, the PDE4B enzyme. And then if you block it, like ahead of time, give high doses of pharmacological doses of a PDE4 inhibitor, you can see it blocks almost all the activity. This is shown at baseline and blockade here for the actual numerical values. So this is saying that 90% of the uptake in the monkey brain is associated with PDE4B because it can be displaced by compounds that are selective for 4B. Okay, we've extended this to human subjects, and this shows those results here. There's, as expected, a widespread distribution of PDE4B in the brain. The highest, though, is in the thalamus. So how could we use this marker to this 4B radioligand in some sort of a way that could be useful and consider its application? So here's a paper. The title is PET Imaging in Rat Brain Shows Opposite Effects of Acute and Chronic Alcohol Exposure on Phosphodiesterase 4B, an indirect biomarker of cyclic AMP activity. The key findings are the acute administration of alcohol ethanol decreased the binding. Increased the binding, excuse me. Chronic administration decreased the binding. Okay, here's some of the data that on the acute effect of ethanol. Radioligand binding was increased. Here's the time course of the radioligand binding. Within 30 minutes, it's increased. And it comes back to normal, let's say, or normal-ish, by 6 to 24 hours. If you look at the average time activity curve from 3 animals in each group, you can see in the ethanol increases the binding. This is consistent with a large number of studies going back to the 70s, which have shown that the acute administration of ethanol increases cyclic AMP activity in the brain. Okay, chronic alcohol, on the other hand, decreases radioligand binding. And that's shown here. This is the non-dependent animal, like a normal animal, and this is the dependent one who has been exposed via the air to ethanol for I don't know, I think it's 6 or 8 weeks. So it has become dependent on the alcohol. If you stop it, they'll go into withdrawal. And what we find here is that the dependent animals, compared to those who were just breathing regular air, it was decreased. So this is, we're now involved with a translation, an exact translational study of that. And put it here diagrammatically, what we found in the rat is that chronic alcohol decreased the radioligand binding, consistent with decreased cyclic P activity. So in the human, this is what we find in the healthy human. We're now studying patients with alcohol use disorder when they come into the hospital for a 28-day withdrawal. And our prediction is that the binding will be low cyclic AMP activity. And at the end of that period of time, it will return to normal, just as these chronic alcohol exposed rats return to normal. We're also, by the way, just starting, I don't know, this month, I hope, a study of the acute effect of ethanol. Acute effect of ethanol, we think, is known to increase cyclic AMP. We're expecting it to increase the radioligand binding. The subjects will be scanned at baseline, and then while getting an intravenous infusion of ethanol, bringing their level up to drunkenness levels, 0.8%. Okay. So what is the therapeutic potential implication? Well, if cyclic AMP is decreased during the initial phase of withdrawal, then maybe you could treat alcohol use disorder or help them to decrease their drinking with the PDE4B inhibitor to increase cyclic AMP. In fact, there have been studies with non-selective PDE4 inhibitors, and they have been helpful in non-treatment seeking patients who want to decrease but not completely stop their drinking, that it is helpful, for that. One of the problems where you can't go up high enough on the dose because there's nausea and vomiting. Well, wouldn't it be great to potentially treat with a PDE4B inhibitor? So this is the pathophysiology, increase and decreases of cyclic AMP with ethanol, acute or chronic administration. The therapeutic implication would be that a PDE4B inhibitor, we might be able to go up to a much higher dose, and it would be helpful during the initial withdrawal period. Also, related to this is that PDE4B is elevated in peripheral inflammation. This is like a known fact. And the myeloid cells have increased PDE4B and decreased cyclic AMP. The elevated PDE4B protein in the inflammatory cells metabolizes and decreases cyclic AMP. So in a similar way, a pan-PDE4 inhibitor, well, there are two examples here, apremilast and roflumilast, are approved to treat inflammation in COPD and psoriasis. Although these are pan inhibitors, there's strong evidence that the mechanism is actually by inhibition of 4B specifically. The first preferential PDE4B inhibitor to decrease inflammation and prevent progression was in a rare pulmonary disorder called idiopathic pulmonary fibrosis. The initial paper was in 2022, and a subsequent multi-center trial, larger in 2025, showed significant slowing of progression in this very badly and quickly progressing disorder. The company is presumably going to move ahead to try to get approval for the rare disorder, but it could in general be useful in several inflammatory disorders, potentially also in the brain. Okay, so this is another avenue for looking at therapeutic applications. Can our radioligand detect elevated PDE4B in peripheral inflammation? And the answer is yes. And this, so there's, PDE4B inhibitor has been shown in 2 articles now to be anti-inflammatory and anti-fibrotic in human disorder. Here's a case where the monkeys were infected with tuberculosis, and you can see the tubercles, tubercular tubercles, I guess, here on CT, and there's increased uptake as expected. So the PET PDE4B radioligand that we have can detect the known increase in PDE4B in this example of peripheral inflammation. Here's the time activity curve for 2 lesions compared to the background normal appearing tissue. Okay, well, how about in the brain? So this study, preliminary results from Paul Parkon, currently a assistant clinical investigator, MD, PhD, sort of in between training fellowship and full faculty. This rat was injected with the LPS, which is an inflammagen from gram-negative bacteria. And you can see it increases the binding on this side of the brain. And if you looked at it quantitatively, you see a big increase in that part of the brain compared to the opposite or control side. So we're extending this study now, and the other beta amyloid is inflammogenic, and injecting beta amyloid will increase the binding in the rat brain. So we're now moving this towards human subjects. Here's the PDE4B in the healthy human brain, showed with it's widespread, highest in the thalamus. And also, I won't go into the details on this, but we've made a radioligand that's selective for 4D. D is the one, if you inhibit D, you have procognitive effects in animals. And it is highest in the neocortex. PDE4B is highest in the thalamus. There's a differential distribution to show that here. So PDE4D is highest in the neocortex. PDE4B is highest in the thalamus. This is shown in the monkey. Okay. What are we planning to go ahead now that we have these two radioligands? Well, we previously found that the pan-PDE4 inhibitor roluprem was decreased during a major depressive episode. We will now determine whether that decrease is just 4B, or is it 4D, or for both of them. And these studies have begun and are directed again by Paul Parkon, assistant clinical investigator in this larger group. Can I go forward? Okay, I'm going to stop there. And to summarize what I've shown is that we have developed radioligands that are preferential for 2 of the subtypes of PDE4. PDE4 is the major enzyme in the brain for metabolizing cyclic AMP. The PDE4B radioligands is being used now in studies in alcoholism and in patients with major depressive disorder. The 4D, we have not yet started the humans, but we will start the humans, hopefully, shortly. Okay, let me move to the second part of the study of my presentation, which is PET imaging of cyclooxygenases. And cyclooxygenases in the periphery we are fairly familiar with. There's COX-1 and COX-2. And they both convert arachidonic acid to PGH2, a common precursor prostanoid. And then depending upon which cell type it's in, it can be all different sorts of prostanoids, different effects. In the human, in the periphery, COX-2 is primarily located in myeloid cells. There's hardly any at baseline, but when there's inflammation, there's a big increase in COX-2, and thus that's why the drug companies developed selective inhibitors of COX-2. COX-1 is a constitutive enzyme. It's present at very high concentrations. It helps maintain homeostasis. It's very high, for example, in the GI tract. It can maintain pH in the stomach. And if you use aspirin or other COX-1 inhibitors, you increase the acidity, and that's why you have a damage. So this is in the periphery. In the brain, it's sort of the exact opposite. COX-1 is the inflammatory one. It's located primarily in microglia. It's in other cells, but heavily in microglia, which are like the macrophages of the brain. And COX-2, surprisingly, is located in neurons. And no one knows what COX-2 is doing in the neurons, but it's there. So we developed radioligand selective for COX-1, which is widespread in the body, in the brain, in the spleen, in the kidneys, and in the GI tract. And inhibition there causes GI irritation. The highest is probably in the spleen. And then we can block that with non-radioactive. So in the baseline scan, we use the radio label occupies less than what binds to what less than 1% of the enzyme. Block it, we give pharmacological doses of the non-radioactive compound, and we can block it in all of these organs. So it is pharmacologically specific to COX-1. It's not blocked by COX-2 agents. So we have extended this to human subjects, and this is the COX-1 radioligand is blocked by low doses of ketoprofen, but minimally by high doses of celecoxib. Ketoprofen, you can see the blockade most effectively by ketoprofen. Ketoprofen is used for pain, particularly in the emergency room, and it is highly potent and highly selective for COX-1. Celecoxib, on the other hand, or Celebrex, this is a high dose, 400 milligrams. It has a minimal effect on, easiest to see, in the spleen. Okay, so in these subjects, human subjects, we gave increasing doses of the ketoprofen and the celecoxib, and we measured the concentration in the plasma. Let's do ketoprofen first. So these were doses up here that gave 3 micromolar of 75 milligrams. The smallest tablet of ketoprofen is 75 milligrams. And then we looked at the spleen uptake in these individual subjects. And you can, in order to get these concentrations down here, we had to grind up the pill and then put it into capsules. This is like 1 to 2 milligrams. So ketoprofen is very potent in inhibiting the binding and therefore presumably inhibiting the activity of COX-1 in the spleen. For celecoxib, on the other hand, we went up as high as we could go at this point, which was 400 milligrams, and we could not even get a 50% blockade. I know from animal studies, if we went higher, we would actually have blocked it all. From this, you can determine an IC50, a concentration in the plasma to inhibit 50%. For COX-1, it's less than 0.24 micromolar, and for the COX-2 compound, celecoxib, it's greater than 2.5 micromolar. And just by the way, celecoxib is not selective. It's preferential for COX-2 over COX-1, but there is some affinity. And this difference here reflects, in part, the fact that celecoxib does bind to COX-1 with about a 10-fold difference from COX-2 compared to COX-1. Ketoprofen is completely selective for COX-1. Okay, so we looked at the COX-1 in the brain. And the COX-1 in the brain is, in human subjects, is in the hippocampus, it's in the visual cortex back here. It can be blocked, as mentioned, by pharmacological doses of ketoprofen. And this was published just this year, I guess. Okay. Something that you didn't notice on those images is that there is, and by the way, nobody knows why COX-1 is so high on the hippocampus and the occipital cortex here. But another one that can be overlooked is the pericentral sulcus. So this is the central sulcus by this line here. What we've done for these images is that here's an individual subject. We separate out the gray matter from the MRI, and then we sample from the PET image. So this stuff in blue is in the bank, the prefrontal bank of the central sulcus. In red is in the postcentral bank of the central sulcus. And then once you've done that, you can blow it up like a balloon, and it becomes very clear then that the uptake, this is the lateral view over here, there's significant uptake for reasons that aren't known on the banks of the sulcus, which you can see when the image is blown up. You might ask, so COX-1 in the human brain, it's the highest in the hippocampus, the occipital cortex, and the pericentral sulcus. It's blocked by ketoprofen. It has a high specific to background binding ratio. In the hippocampus, 2.7. That's considered high for PET imaging. It has good reliability. This is an interclass correlation coefficient, 0.84, and a very good test retest, absolute variability, test retest in healthy subjects. That's 6.4% is good for PET. So in our opinion, and our job is to develop PET radioligands, PS13 is fully fit for purpose to measure COX-1, and there's no improvements needed for a C11 label tracer. And our standards are pretty high. Okay, so how about the COX-2? So for the COX-2 radioligand, we found no specific binding in healthy monkeys, except one place. So there's like virtually none, and that was in the ovary. Here's the baseline scan of a female macaque, and we looked at blockade by celecoxib, and a very astute former postdoctoral fellow noticed that actually there's high uptake in the ovary, and it can be blocked by celecoxib. And it turns out, I didn't know it, but the ovaries are known to have a high level of COX-2, and COX-2 inhibitors can have effects on ovulation and pregnancy. But I don't know the full details, but it's showing up in the right place. Okay, so what we're interested in, though, is to try to see, can we see anything in the brain? And basically, in the healthy monkey brain, we could not see anything. And that's sort of expected, because at basal levels, there's very little COX-2. In order to increase it, what we did is we injected a monkey with this LPS. The LPS was injected in the caudate. And sure enough, COX-2, but not COX-1, was globally upregulated day one after LPS injection. So it's showing that in the brain, as in the periphery, with inflammation, there can be a rapid and dramatic increase in the density of COX-2, which is primarily located in the neurons. If you give a second injection, it becomes even more dramatic. And this was published now 5 years ago. Okay, so the big question for us is, well, we know that we have something that can detect the ovaries. We know we can detect it in the monkey brain if we inject an inflammagen. Are we going to be able to measure this in human subjects? Because we aren't going to be able to inject LPS into the brains of humans. So in this first paper, we looked at subjects with rheumatoid arthritis. Patients with rheumatoid arthritis in the active lesions have a massive increase in COX-2. And that's why some of the there are more improved, better treatments since then. But you can also treat rheumatoid arthritis with COX-2 inhibitors like Celebrex. And you can see here in this human subject. So the radioligand works for the COX-2 in monkeys and in humans, at least in the periphery where it's elevated. What about in healthy human subjects? And the answer was, and this is, I guess this is just this year. COX-2 in healthy humans, we can measure it. And it's primarily located in the neocortex, in the healthy human, and it can be blocked by celecoxib. So this is in human subjects. So how are we sort of putting this all together in a model? COX-1 is primarily located, this is a working model, there's some evidence for it. COX-1 is primarily, but not exclusively, located in microglia. And COX-2 is primarily located in neurons. We have found that LPS, and I can also say beta amyloid, they both act via this toll-like receptor 4 on microglia to increase the inflammatory response and release cytokines, and cytokines release COX-2. So this is the model that we're working on here, where COX-1 will be in part a mediator for the release of cytokines. If you inhibit COX-1 in the brain, there's evidence that it is anti-inflammatory. In the periphery, you inhibit COX-2. So we're working on this sort of a model for it. COX's future directions. COX-1 is a biomarker for increased microglia and inflammation. It's being studied now in our lab in several neuropsychiatric disorders. COX-2 we're looking at as a potential dynamic biomarker, that it markedly goes up. You can say with the presence, the neurons increase their COX-2 and they mark an inflammation in the brain. Also, if an anti-inflammatory is effective, it should decrease the COX-2. So we're looking for this in animals and some human studies. In summary, we've developed a PET radioligand for COX-1, COX-2, PDE4B, and PDE4D. COX-1 may be a biomarker for microgliosis, increased number of microglia, the macrophages of the brain. COX-2 may be a marker of active inflammation in the brain and the periphery. PDE4B can be both a marker for cyclic AMP signaling because of the phosphorylation and the negative feedback, and of inflammation. And inhibition of 4B is anti-inflammatory in the brain and should also be, and there's limited evidence, in the periphery, and it is limited evidence in the brain itself. PDE4D inhibition is pro-cognitive, and we'll be starting human studies soon. We'll be looking at that in certain cognitive disorders. So back to the question, are oncology and neurology models for PET in psychiatry, being able to diagnose disorders and to use it potentially for treatment? My opinion, not really, because psychiatry lacks these disease-specific biomarkers. We do not have an amyloid, a protein, to diagnose depression. That must be there, and if it isn't there, you don't have depression. We just don't have that. So how can PET be used in psychiatry? One is to explore pathophysiology, as I've mentioned here. As a group, can we find decreases of cyclic AMP activity in patients during a major depressive episode? It can be used potentially for precision medicine, so identifying subgroups with a preferential response. An example there would be depression. So if we find that there's a decrease in 4B, reflecting low cyclic AMP, that's the group that should preferentially respond to treatment with a PDE4B inhibitor, the first one of which has been studied in human subjects in idiopathic pulmonary fibrosis. And it can also be used to facilitate drug development. The typical use of PET in drug development is drug occupancy. So you have a therapeutic candidate, you have a radioligand for the same target, and you see whether your therapeutic drug gets into the brain, crosses the blood-brain barrier, and occupies a significant number of the receptors. This information can also be used to convince pharma to pursue targets. I think there's very strong evidence that PDE4B inhibitor would be useful in withdrawal from an alcohol use disorder. There are studies now where 4B are looking at peripheral inflammation, but in order to get them to try in depression, and particularly alcohol use disorder, we're going to need evidence that it would be useful. And so if we can show these abnormalities after acute and chronic alcohol, it'll be more likely for pharma, which is generally reluctant to make drugs for drug disorders. Okay. My conflict of interest, maybe I was overly positive, I don't know. But clinical research fellowship in psychiatry that uses positron emission tomography. I have a position available. It's a PGY4 or recent graduates. It is to train transferable skills in good clinical practice, which GCP, which are the international standards for how to conduct research. And you learn about FDA regulations because all of our radioligands are FDA regulated investigational new drugs, experimental design and data analysis, and it provides good training for transition to academia, pharma, or the FDA. This is not training just to be a PET researcher. It's a training to be a clinical researcher with a strong psychopharmacological bent. The salary, I want to mention that you may apply for a loan repayment program of $50,000 per year tax-free. And I've had someone who's on his third year now. So that's a lot of money, $50,000 per year tax-free. It helps for some high loans. And I'll forward my slides, but here's a here's a description of the general program available for PGY4 in psychiatry. In addition to that, there's also clinical fellows. With that, let me stop. And I'm happy to take questions.
Thank you very much, Dr. Ennis. It was a great talk. If folks are have questions, please feel free to unmute or put in the chat. So I see Dr. Gorelick, you have a question. Did you want to unmute and ask, or do you want me to?
Yeah, well, first, I don't know if Dr. Ennis remembers me, but I was at NIDA Intramural for 24 years, did some pet research in collaboration with Jim Frost at Hopkins. So I'm very familiar with using PET as a technique to look at the possible neuropharmacology or pathophysiology of, in my case, cocaine use disorder. And then one of your colleagues collaborated with the lab I worked with Marilyn Eustace on some cannabinoid receptor ligands. Anyway.
Right. So we image the CB1 receptor.
Right. Yes, I'm a
in both
co-author on some of those
alcohol use
papers.
disorder and cannabis abuse. Yeah.
Right. So I think it's very helpful at the early stage of drug development in terms of elucidating the pathophysiology. For example, in the studies that I did with Jim Frost, maybe manipulating the mu opioid receptor system in the brain might be helpful for reducing cocaine use. No one followed up on it. But my practical question for the trainees that you're trying to recruit, does the NIH intramural program, at one time they had such a program, I left 12 years ago, allow trainees or faculty staff, at least now last year, to apply for extramural funding? Because in these days, it's very hard to get an external position unless you're bringing some funding with you. And that's certainly true in the Department of Psychiatry at Maryland, where I am now part-time.
Absolutely. And many years ago, it was found to be a disadvantage of the intramural program that the PIs, that the trainees, like the clinical fellows, for example, were not involved in writing grant applications. And actually, I mean, they can be abused extramurally. I've certainly seen situations where they do all the writing and don't get none of the credit. So what they instituted many years ago, actually before I started in 2001, is that they set up a training program, a very good training program here on how to write grant applications. And there is one in particular that they go for, which is this Career Award K99. It's called a Kangaroo or Jump Award. So it's for 5 years. You write it, let's say, in the intramural program. We have a course that goes over a full year for how to create it and do it, and they actually write it up, and they have high success rate. And then they use that for the first, let's say, 2.5 years to gather data at NIH, and then they can bring the rest to the university. So they become very attractive candidates to be recruited at universities because they bring some money with them. K99 award.
Yeah. Kangaroos.
Hey, Gloria, there's somebody on a conference room system that has their hand raised. They may have a question.
It's been up for most of the talk, so I don't know if they meant to do that, but please feel free to unmute if you have a question. And while we're waiting here, Dr. Ennis, do you have any comments on how you think about how to conceptualize timing for using a PDE4D inhibitor to improve, for pro-cognitive effects? Like, is this something do you think about this as a therapeutic that's going to be used, for more advanced cases, or it could be used potentially earlier in the course of illness?
We really don't know. There's only been one use of a PDE4D inhibitor, and that was in patients with Fragile X syndrome. Huh. And it was done for treatment of the Fragile X symptoms and disorders, but it was looking mainly at safety and tolerability, and it was quite well tolerated. It did increase the cognitive performance in the patients with the Fragile X, but it was not powered or organized for that. It was just powered for trying to find side effects. Really don't know. But one way to help drug companies encourage them to look at it would be, well, we can at least measure the 4D binding, and we predict that the 4D binding, would be decreased, and therefore you could increase with a 4D inhibitor, and maybe those patients with Fragile X, maybe they would start with Fragile X or dementia or something, would be the ones most likely to do it. Mm-hmm. So it's trying to gather physiologic and pathophysiological data to guide the rational design for drug evaluation in human subjects. So, and for all of my work, I have numerous targets that I work on, or could work on, and I try to select those for which I think there's most likely to be an important pathophysiological abnormality, and that there is some reasonable pathway for the future treatment. So PET is expensive, and I'm always interested in some clinically meaningful, new, improved treatment.
Yeah. Okay. And maybe we could close, since I know you are very passionate about mentorship and training, that unfortunately, nationally, we are seeing an exodus of people leaving scientific research career paths. And I know that you're trying to encourage folks to enter this arena. If you could share with our young trainees who are on the call today, what excites you the most about a scientific career in this era? If you have one or two thoughts on that, so we end on a note about the future.
The neuroscience has blossomed, as everybody knows, since the time when I got in the late 70s, got a PhD in basically neuropharmacology, and there's more and more and more. So there are such great opportunities now to work for new and improved treatments. Look at ketamine, which basically I think was discovered in 2001. Look at the use of psychedelics. Look at the use of transcranial magnetic stimulation. Others are coming. So I think the most exciting thing is what I remember when I was doing studies initially of the cocaine receptor, which is the dopamine transporter. The dopamine transporter, by the way, is decreased. It's lost in Parkinson's disease. So if there's a decrease in the cocaine receptor, it can be a diagnostic agent for Parkinson's disease. So that drug was approved for the clinical diagnosis of Parkinson's disease in the European Union and the US. I remember I explained this to my mother, of very humble origin, and I told her, well, we make this radioactive drug that's 300 times more potent than cocaine, and we give it to people. And she said, oh, Bob, stop joking. What do you really do? Yeah, that's what actually we really did. And it is now approved to aid in the diagnosis of Parkinson's disease.
Wow,
and she said, but I'll tell you, please keep in mind, what you really want to try to do is get people better.
Yeah.
And she was right. Not humble background, no college education, but she is right, and it's a worthy cause. I recommend others take it up in psychiatry.
That's very meaningful words. We actually got one more question about the role of PET in precision medicine, and if you think that will, in the future, at some point, help with defining diagnostic subgroups or kind of reducing clinical heterogeneity.
Absolutely, and I think it's critically important. And depression would be a good example. I mean, depression is highly diverse in terms of symptoms, genetic causes, predispositions, treatment response, etc. I'm convinced, in addition to low cyclic AMP activity, that a subset of patients, that another subset have inflammation. So there was really a seminal report about 5 years ago from the University of Toronto, Jeff Meyer, who looked at a radioligand for inflammation. It was originally developed here in this lab. And he measured patients with a major depressive episode. And he found, like many others, that there was a group increase in the inflammation in the brain as measured by this inflammatory biomarker. He then, quote, treated the patients with celecoxib, which is this COX-2 preferential inhibitor. and treated them, I don't know, for 2 months. And he found a modest improvement with the COX-2 inhibitor. But almost all of the responders had elevated inflammatory marker at baseline. So that was showing that this inflammatory marker, if replicated in everything, could identify a subgroup that would preferentially respond to an anti-inflammatory treatment. I think that's the way going forward. That's precision medicine, patient stratification.
Yeah, really exciting stuff. All right. Well, thank you again so much, Dr. Ennis. We're very grateful for your time. And if there are any trainees on the call who are interested in learning more about the fellowship program, please reach out to me and I'd be happy to connect you. So thank you so much, Dr. Ennis.
Thank you for having me.